Next, we have Dr. Robert Pack, Professor and Associate Dean for Academic Affairs here at East Tennessee State University in the College of Public Health. Also, Nicholas Hagemeier. He is a pharmacist, MD, a PhD, and Assistant Professor of Pharmacy Practice. Bill Gatton College of Pharmacy, likewise here at East Tennessee State. If you would welcome them to the stage, please.
Good morning. How are you? All right. Well, thank you so much for being here. This is such an important topic, and a topic that's near and dear to my heart and many of my colleagues here. In fact, here at ETSU, we have a prescription drug abuse working group that my colleague, Dr. Hagemeier, is going to talk about specifically. But if you're part of that working group, if you go ahead and stand up, I know there's a number of us here. Quick, there's a number of folks, from around the community, around the campus. So these are some of the folks that are engaged in the topic here. Thank you for being here. Thank you for coming down to East Tennessee, and thank you, Dr. Nolan, for making the connection to bring this here. It's such an important topic, and we're pleased to be able to speak to it. Well, I'm a professor of public health, so I'm going to talk a lot about some of the data and some of the trends that Ms. LaBelle happened to bring to our attention today, and I'm also going to talk about prevention. So just there you go. It's going to come up. Here's what we're talking about with respect to prescription drug abuse. This is the prescription drug abuse and misuse. This is using without a prescription. We all know this. And of course, this is in the media all the time, right? All the time. These slides are kind of old. Look at this. Limbaugh, Johnny Cash. This fellow was an artist. Now this is an interesting slide an interesting picture because this is Eminem's album Relapse. This is a composite photograph made up of pills. He had a massive prescription painkiller addiction, and since his next album was called Recovery. Of course, we lost some very talented actors and musicians as well. So we see it all the time in the media. Here's what we see, though, in Appalachia, right? We see this. Father says we didn't feed our babies for days. Guilty plea in the robbery case, OxyContin cuts trail of local destruction. Now, this is an old slide. I think if I was to make this slide right now, I think we would have one that had much more much more hydrocodone, and that would be a more prevalent topic today. Of course, some of the topics that have come up today already are going to be mentioned again and again. This is an important slide because these are the painkillers sold in kilograms per capita. Now, one thing that I noticed from Ms. LaBelle's slide was the slide that she showed that looked like this was actually overdoses. And so there is a strong correlation between the two, and we'll talk about that in just a moment. These are age-standardized usage of milligrams of morphine equivalent. Now, it's really kind of tough to tease this out because the size of the counties out west is so big. They're so big, but look, you can begin to see the red, the darker red here in Central Appalachian region. It's a little bit higher, but look at Florida. Really, for a while, from 2008 to 2010, the top 25 prescribers of oxycodone in the nation were in Florida. They're actually in that county right there. Of course, this is sort of what we see in Appalachia still. This is where we are right here, and we have dark is worse. Have a massive use of painkillers here in Central Appalachia. Biggest part of our problem is we don't have a lot of data that we can continually gain access to really talk about what this is. Look, this is an old slide, but we have proxy data. We can talk about sort of risks and proxies for these risks. For example, we found out from the state that in this county, Washington County, for these three conditions, well, neonatal abstinence syndrome, right? Babies born that are addicted to opiates. We're 5th ranked in the state. Sullivan County is 6th, next county up. For hospitalization billings, 2nd, and Sullivan County is 3rd. So we have a challenge in gaining access to and using data consistently without having to go through just proxies. I'd love to see this map right here updated every single year, so we could also tell whether or not our interventions are having an effect. Dr. Mutter, I don't want to steal your thunder. I know you're going to show this progression slide, but I want to mention that what happens is in Tennessee, every one of the counties east of Knoxville have a prescription rate for opioids per 100 people over 141. So what that means is, on average, every person in the counties east of Knoxville, these 15 counties right here, every person has 1.4 opioid prescriptions on average. Is it a rural problem or an urban problem? Well, it turns out it's both. These are drugs, misuse, non-medical use of prescription drugs in urban and rural, and look at that, it's fairly consistent. A little bit higher in rural areas for some. And then this is broken out with a little more resolution. This is SAMHSA data, pretty recent, 2012 data, and these are metropolitan, urbanized, non-metropolitan, and rural. And this is actually quite helpful because, I mean, these are some of the smaller towns, but not the towns that aren't quite rural, right here in the middle. And you can tell that there's a distinction for pain relievers, tranquilizers, stimulants, and sedatives. So we'll talk a little bit about overdose and treatment. This is these are Tennessee data. It's predicted that the treatment seeking for opioids is going to surpass that for alcohol this year. And of course, this is what we see in the nation. Now, these little stars right here mean that this number is statistically significant than from the other numbers down lower, and of course, you can tell that that's true. These are folks who are going into treatment for painkillers in the nation. And of course, we've seen an increase in overdose deaths. Now, I like this slide in particular because a lot of the slides that are put out right now actually have they sort of start right here. And when that happens, it sort of levels out, right? It doesn't look quite as dramatic, but in reality, for a long time, this wasn't quite, the curve wasn't really happening. But it really ticked up right here. And there are a lot of reasons for that, and I anticipate that some of my colleagues are going to mention those this afternoon. Of course, you've already seen this. And in Tennessee, we have the exact same problem in terms of the curve. 250% increase in overdose deaths in Tennessee. So let's go back to this slide right here. Pretty tight correlation between sales, treatment admissions, and death from overdose. Pretty tight correlation. And this is starting in 99 to 2010. Okay, so Appalachia specifically. Well, again, it's difficult to get the consistent data between states, but I'm going to show you a couple of geographic distributions here for some different individual states. This particular one, this is a 2003 slide that came from the Office of the Chief Medical Examiner in Virginia. And these are the drug-related deaths by locality residents back then. Well, what's it like today? This is the latest slide. It's pretty similar, except now we see this creeping out over into the D.C. area and then over here in the, I don't know what that's called, actually, part of Virginia. But, and then we also see the same sort of topic in West Virginia. This is a fantastic study done by an EIS officer, Epidemic Intelligence Service officer, who was stationed in West Virginia in 2007 and 8. I'm sorry, 6 and 7. And Aaron Hall is his name, and he looked at death records for overdose deaths and found a 550% increase in overdose deaths from this period of time. And this is really interesting because Ms. LaBelle mentioned this and articulated it quite well. What's happening is when people are closer on down the continuum, that's when they begin to doctor shop more, right? We recognize this. So in this case, doctor shopping was associated with 21% of deaths, but diversion was associated with 63% of deaths. And of course, prescription opioids were taken by 93%, of whom only 44% had a prescription. And of course, these are the specific data. This is some of the tables. This is interesting right here, the methadone. 40% of the deaths had methadone associated with them. And of course, well, okay, anyone here from West Virginia? What's going on right here? Southern part of the state. This is Southern coal fields, right? And it's pretty extreme poverty, as we all recognize. And in fact, if you overlaid this on top of that little picture of Virginia, right? That part's right, the darkest part's right there. And I'm sure if we could get the same data for Kentucky, it would be darkest right here, right? In northeast Tennessee. So those are some of the overdose statistics by county. Here's some interesting data that Dr. Pelosi put together from CDC. Basically, different studies and what the top drugs of abuse were that caused the overdose deaths. So back in the 01, 3, 2, 4, and on up into more recent times, this is methadone, morphine, methadone, up to OxyContin. I imagine that if this were done today, that we would begin to see OxyContin a little greener there for a little while, and then hydrocodone overtaking that over time. Now, a couple of statistics from some journal articles. These are important. So these are some risk factors for overdose, poisoning, and abuse among privately insured patients up in Maine. Now, what this means is this is an odds ratio. This basically says a 1.96 odds ratio. It means basically it's 2 times the risk. Okay, so there's 2 times the risk. So if you had the behavior of using 3 plus, more than 3 or more pharmacies to get your opioids, you're twice as likely to be to have an overdose. If you had a rapid opioid dose escalation, 1.6 times, or about 60% higher. Now look at this one. An early refill, that's a significant predictor right there. 6.5 to 6.5 times the risk as someone that didn't have an early refill for an overdose or poisoning. And then, of course, 2 times the risk for folks who had more than 12 opioid prescriptions in 3 months. So these are some of the things that you can look for. And of course, this was articulated well earlier, but this is another way of looking at the data from with respect to where folks tend to get their substances of abuse if they're new initiates to prescription drug abuse. And basically about 70% get from a friend or relative. And then of those people who get from a friend or relative, most of those get them from just one doctor. And this is some additional data. 66 among kids, grade 12. These about 66% got their amphetamines from friend or relative. Tranquilizers about 78%, and 70% for narcotics other than heroin. So, this data backs the other data up pretty well. So we know that these drugs have a lot of value on the street. No one knows that better than you. And we've been predicting this for a while, that heroin, over time, as we begin to crack down on prescription opioids, heroin, over time, will backfill the market for prescription pain pills. And, of course, we're starting to see that. Ms. LaBelle mentioned this earlier. I'm just going to add a little detail here. This is Chris Jones. He's an epidemic. Well, actually, no, he's at the CDC. I think he reports to the director. Dr. Jones had this empirical study this year that demonstrated that basically heroin use among non-medical users of OPRs or opioid pain relievers increased in this time frame, with most reporting non-medical use of opioid pain relievers before initiating heroin. Of course, we saw this coming, and it's now validated. And I pulled this slide from the National Drug Threat Assessment. I couldn't find a more updated one, but this is a very fascinating slide about what's going on with heroin and transportation routes. And I think it probably says something toward the question of homeland security as well. Okay, so there's a lot that has been discussed about preventing access to prescription drugs and prescription opioids. In Tennessee, here's our situation. We from the Prescription Drug Monitoring Database in 2008, there were about 43 hydrocodones prescribed per Tennessean in 2008. It's a pretty amazing statistic. A lot of people talk about OxyContin for a long time. It's really, I mean, this is hydrocodone that we're talking about here. OxyContin's really right there. It's on down the list. That's 2008. This is 2010 data, published in 11, I think, and the number's about the same. 275 million doses of hydrocodone for 6.2 million people. It's about, it's been said that's 51 pills for every man, woman, and child in older than 12 in Tennessee. Of course, we have the Controlled Substances Monitoring Database in Tennessee and the one in Virginia. And I point this out because it's just so important. And we're going to hear about this in detail today. But it's so important that these begin to talk to each other and there's interoperability. I know that that's a goal, and it may be right. We may be right on top of it. I haven't kept up with it in the last few months, but I know that we're getting close, or I hope we are. And of course, we have an active state government on this topic. Our governor has signed into law the Prescription Safety Act of 2012, which requires use of the CSMD. That's very positive. And then, of course, the action step implementation plan that he has put together with his Commissioner of Health and Commissioner for Mental Health and others, and safety. So there are some very talented folks around the state that are working on this topic and are actively engaged in this using evidence-based approaches, and very impressed with the intensity that they're bringing to that from the state government level. A couple more things I want to mention. There's an opportunity to do something about this from the prescribing side. There's this newer concept of the morphine equivalent dose and prescribing guidelines that are beginning to have an impact on how this is being done and on overdose deaths in the nation. At this point, there's some good epidemiologic evidence for a significant increase in opioid related morbidity, mortality above 100 to 120 milligrams per day of morphine equivalent. And this is just one of those studies, basically showing above 100 is about a 9 times increase in risk for overdose. And of course, it ratchets up quickly after 50. And there's some really interesting work done out in Washington State, basically saying if you can control this morphine equivalent dosage per day, you can begin to have a really substantial reduction in overdose rate. And this was work that was done at the University of Washington and done with their workers' comp data. And this is interesting because when I first saw this, I was like, well, okay, this is the overdose, opioid-related deaths, right? And then there's a significant drop. And anytime you see a significant drop like this, when you're a scientist, you tend to think, well, okay, that may be a regression to the mean, and then we're going to see what happens over the next couple of years. So I contacted this fellow. His name is Gary Franklin, and It turns out that they're sustaining this decline at this point, which is really good news. So there's the intervention that they're putting in place is an attempt to get people to recognize that the more likely that someone is above 100 morphine equivalents per day, the much greater likelihood they are to be a victim of overdose. So we're trying to turn the morphine equivalents per day down. And of course, this has been some guidance from the CDC for a while, but they've had this on their website for a couple of years. But now we're having a lot more, there's a lot more epidemiologic evidence for this. Of course, there are great attempts to try to reduce the number of prescription opioids that are out in cabinets. And we're going to talk a little bit in a few minutes about, Dr. Hagemeier is going to talk about some of our local efforts to this. This is actually an event that was put on by the College of Pharmacy here, and Dr. Gray, who's one of our colleagues on the working group, who is spearheading some of this prescription drug disposal efforts here in East Tennessee, along with law enforcement. Last thing I'm going to talk about is really prevention. I want to highlight prevention for a couple minutes. What about youth? Okay, well, we know that there's a significant number of kids who begin to try prescription drugs for non-medical reasons for the first time every day. So what's happening? Where are they getting these? This is an interesting study by Sean Esteban McCabe. He's up in Michigan. He's done a lot of work on this behavioral epidemiology of prescription drug and prescription opioid abuse among youth in particular. And one thing that they found was they looked at a sub-analysis of where these kids were getting their pills, and about 27% obtained them from a dentist. They had them left over, rather, from a dentist, about 45% from an ER doc, and about 38% from another physician. So Ms. LaBelle, again, presaged what I was going to mention here, but we really need to engage dentistry on this topic as well. And of course, the most common drugs for illicit use are, I guess, really is marijuana. But if you add up all of the pills here together, you come close to, if not exceed, marijuana. Of course, these aren't mutually independent, but there's a lot of pill abuse among teens. Now, the next slide's about marijuana use, but I point this out because there's a real correlation here. It's an inverse correlation between what's going on is as people perceive the risk to be lower, well, in the population, you might expect the use to be high. And in fact, that's what we see with a lot of different drugs, is as perceived risk peaks, there's a perception that marijuana was very risky right here in the late 80s, early 90s, right? Use troughs, it goes the lowest, right? And so this is important for prescription drug abuse because kids tend not to think that these are very risky pills or risky drugs to abuse. So these are data from Drug Free America, but basically you can read through those. It's pointing out that there's not a whole lot of high risk perception. Last few slides, I want to mention that if you're going to do something about prevention, where are you going to focus? You're not going to focus here. You're going to focus here. This is 12 years old, 10, 12 years old, and so it turns out that there are a number of things that can be done with youth to prevent substance abuse. In fact, a whole lot of resources have been put into this in the country, and primary prevention is preventing use from ever starting in the first place. This is a screenshot of a SAMHSA National Registry of Evidence-Based Programs and Practices. There are over 300 interventions at this website that have been proven to work. They're there. We've paid for them as taxpayers. They're NIH-funded studies that have been peer-reviewed and disseminated. In fact, they have an amazing level of detail that's been put in layman's language you can search through all these different types of interventions. These are prevention interventions that have been proven to work. You can search through all these different interventions and then pull up real data that point out things like compared to control group students, students in the intervention group were significantly less likely to have progressed to reporting any substance use by age 21. These are kids that were in a primary prevention program in an intervention group against a control group. They did better. So this website is full of these details. These are programs that our communities can access. They can access them going to these investigators and requesting their intervention materials. And I strongly encourage coalition groups and others to get engaged in these evidence-based practices. So the second to last thing I want to mention here is that, of course, parents have to know what is going on. So we have to talk to we have to talk to youth. We got to give them the skills to prevent prescription drug abuse. Got to talk to the parents. They know that if they've got opioids in their home, that they know that they have to monitor what's going on in their house. They got to secure them. Are they locked up? Do they know exactly how many pills they have in their house? And do they know how to dispose of unused portions very carefully? So we know it works. We know that parenting programs have a pretty significant effect and impact. They have what's called a nice effect size in public health prevention interventions. We know that we need to change risk perception in youth, and we've got to educate parents about what's going on with this in the home. I'm going to turn this over to my colleague, Dr. Hagemeier, who's going to take a few minutes to talk about our approach that we've taken. I'll tell you, I've been looking at prescription drug abuse for several years, and as a research topic and as an intervention topic and a public health topic. And every now and then I feel like I'm working in isolation. I used to feel like I was working in isolation. Well, it turns out a number of us felt like we were working in isolation. And Dr. Lloyd's laughing, and he's going to probably talk about this today as well. But we were at a meeting one time, and we said, well, why don't we get together and just talk about what each other are doing? Because we were always so frenetic. And finally we said, okay, let's go ahead and schedule that meeting, and let's just sit down and talk, and let's see what's going on. And Dr. Hagemeier is going to talk about the rest of the story.
Thanks, Rob. Well, I'm one of the faculty members here. Dr. Nolan mentioned that it's honored to be here and honored to be a part of this chat. And I'm also honored to be a part of this working group that's trying to make a difference. The things that we're talking about, how do you make those actionable? And I want to talk to you briefly about how we're trying to approach that here in East Tennessee. So really, I'm going to tell you a story quickly about some of the things that have been done in the past, and then I'm going to tell you just in the last couple years where we're heading and give you a little bit of vision. East Tennessee State University has had its roots in community-based research and community-based efforts for quite some time. The Office of Rural and Community Health, I know Chris Bowers is here. She was very instrumental in that. Appalachian Regional Commission that published a report about mental health disparities back in 2008. So some of this stuff's been going on for quite some time. But we had actually a pharmacist in town that's also a business owner that shortly after I arrived here in 2011 really challenged me and challenged some other folks at ETSU to do something about this. He said, you know, you all have the resources, and I'm not even sure that we knew that we had the resources at that time to do something about this. But as an outsider looking in, he saw that the ETSU had some things going for it, and for that reason, we took some steps to make what he thought was possible really so. Go back one here. So we started in the early, I say the early year because that's really about all we have so far. In spring of 2012, we started a prescription drug abuse working group. We started with about 5 people, I believe. Quickly had 20 from around ETSU, from around the community. Now we have about 20 that attend each meeting. and we have almost 50 folks that are clinicians, researchers, community outreach folks that are on the mailing list for the meeting that we have every month. So this is really taken off, and really what we've tried to do here is make this into a center, but it's not really a center. But we're trying to look at community outreach, we're trying to look at education, we're trying to look at training, we're trying to look at solid research as well. So we're trying to take the holistic approach that we know it's going to take to address this epidemic. And really what this working group does is serve as an area a way to pool our expertise. Give you an example, there's an outreach group in the community that's trying to help women that are addicted to or abusing prescription drugs. They needed some help with evaluation. So coming to this working group meeting is a good way that we've partnered some people that have evaluation skills here at ETSU with some folks in the community that could really use that help to show outcomes based on what they're trying to do. Out of this meeting, we said we ought to try to get some money to do some things here. So we were made aware of a grant that was put out by the NIH and the National Institutes on Drug Abuse. It's an R24 mechanism, and it establishes diversity-promoting drug abuse research programs across the United States. And we were awarded one of these grants in June of 2013. It's a $2.2 million grant over 5 years to do 3 projects. The aims of the R24 mechanism, I guess, there's a purpose behind that, and the purpose is to train more people from disadvantaged backgrounds to be drug abuse researchers. Well, that seemed like a pretty appropriate place. It seemed like we had our name written all over it, this grant mechanism, because you don't have to go far, and Dr. Nolan mentioned it earlier, that almost every one of our students has a story about prescription drug abuse. We have students in the College of Pharmacy that have lost parents to prescription drug abuse. That's why they're here. It's pretty impactful. So our goal through this funding mechanism is to get more people that are from this area, have these prescription drug abuse experiences, to get them doing prescription drug abuse research. We're also in the process going to develop faculty as well. We're going to develop some infrastructure here so we can keep this going on, so we can sustain it. We're going to conduct some solid research, and I'm going to tell you about that here, and then we're going to tell you all about it. We're going to disseminate that. So these are the names of the 3 projects that are within that grant mechanism. The first one is healthcare provider communication and prescription drug abuse. The second one, patient-provider communication. So these 2 are related. And then the third one, Dr. Gray, that's here, is taking the lead on this, is looking at what do we really get from take-back events and from drug donation boxes. So what's the metric that we normally use for drug donations? We measure it in tons, right. What else do we know beyond tons? We really don't. It could be tons of Centrum. It really could. So that's one of the things that we're trying to do is say, what are we really getting? And we're really blessed to have a good relationship with law enforcement around some of our communities here and the DEA to look at some of these data. So I'm going to tell you a little bit about that too. We did a prescription drug abuse symposium in 2012 and did a little survey instrument there. I love doing surveys, and I'd do them all day if I could. But we asked prescribers and pharmacists. Of course, we have small numbers here, but take a look at this. The percentage of patients abusing opioid pain relievers. Prescribers estimated about 17%. Pharmacists estimated 40%. The percent of patients that have a legitimate medical reason, prescribers were well over 80. Pharmacists thought about 62. And these numbers too, percentage of Tri-Cities prescribers who overprescribe opioid pain relievers. It was amazing how many we had in both of these groups that said, I think it's a problem, but it's not a problem in my pharmacy, and it's not a problem in my clinic. So we took these data and figured out that we could turn some of this into some bigger research questions. I did a survey. I'm a pharmacist. I worked in retail for 9 years, also PhD trained, so I came back to do a research degree really for the purpose of trying to figure out how can I help prescription drug abuse. I felt completely inadequate as a community pharmacist to how I was going to really help. If someone came to me with an addiction and even told me that they had it, if they threw me the bone, I had no idea what to do with it. No idea. And I had a feeling I wasn't the only one, and it turns out that that's the case. So I did a survey of Tennessee pharmacists. This is an N of about 640 pharmacists from across the state, pretty evenly distributed, and there weren't really any differences across the state. Pharmacists thought about a little over 20% of their prescription volume was opioid pain relievers. They thought about 53% were for a legitimate medical use. That's concerning to me. That means 47% is not. But we have a corresponding responsibility per regulations to ensure prescription legitimacy. That was concerning. I thought the 62% was legitimacy was bad when we did our first study. Then I do this again, and then it's even lower. They perceived about 25% of their patients to be abusing, almost 30% to be addicted to opioid pain relievers, and about 14% that were diverting, but were filling them. So why? I don't know if you all have read this or not. It's a great article that was published. It's really short, 2-pager, about why doctors prescribe opioids to known opioid abusers. I've really wanted to write one from the pharmacy perspective, and I have yet to do so. But it's a tough thing. We've talked about education this morning. We've talked about training. I can tell pharmacy students, I can tell med students all day long about the problem, but if I don't train them how to do it, how to have these tough conversations, I think that we're not going to have a whole lot of impact. So that's something that we're trying to do here. Why doctors prescribe opioids to non-opioid abusers? Treating pain pays more than treating addiction is one argument that's put forth there. And I think that from the pharmacy perspective, it would probably be pretty similar, that we're not judged on how much time we spend with patients. We're judged on how many prescriptions we fill. And that's our metric that we're most concerned about. So filling more prescriptions is usually perceived as a good thing. Prescription drug abuse is a problem in my practice setting. This year, pharmacists, 87.5% agreed. I think prescribers spend enough time communicating with patients about opioid pain reliever abuse potential. 6% agreed. Again, we see it where I think it might be somebody else's problem. I received some hate mail doing this survey. I did. I had some pharmacists that said, it is not my job. First of all, they said, I bet you get to eat your lunch sitting down. That was the opening line. And community pharmacy is a busy place. You often don't have time for lunch. The next comment disturbed me. Was, it is not my job to detect prescription drug abuse. Yeah, it is. It is. It's in the rules of the board. As a professional, it is your job. So that's what we're dealing with. There are a lot of things here where it's the easy thing to do is to place blame on somebody else. So we asked what we thought about improved communication. Everybody agreed with all of these pathways that improved communication is needed. Patient-prescriber communication, prescribers and pharmacists both thought that we need improvements there. Same for community pharmacist and patient, same between prescriber and dispenser or community pharmacist. So projects 1 and 2 of our grant are really focusing on communication. It goes beyond education. It's using evidence-based research to give somebody the tools that they need to be able to have these tough conversations with patients and tough conversations between dispensers and prescribers. That's where we're going to focus on 1 and 2. Project 3, Dr. Gray's leading this. Here's your hydrocodone quiz. Speckled with strength. 7.5, 7.5, 500, all right. How about these blue guys here? 10 500s. Those are the more potent. And then these are the orange, Norco, 7.5, 325. This is a picture of a hydrocodone pie. That's a 55-gallon drum lid, and that is from a donation box in a local community that we received was that last week, Jeff? Over 3,000 in 4 bags, 3,000 hydrocodone. I have no idea where that came from. I don't know if it was somebody had a come to Jesus meeting. That was what everybody was hoping around the police station. We doubted that. Whether that was somebody that ratted out a dealer. If that was the case, they were expecting a homicide. That's a lot of money. It's a lot of money. But this is what we're getting out of this. So this is where we're trying to go beyond tons and look at what do we really get in these donation boxes, what do we get in take-back events. So this is just from the donation boxes since June of 2012. We've got over 10,000 hydrocodone, 5,000 oxycodone. Tramadol is big. Tramadol is abused. And then some of the benzodiazepines too. So we're just trying to put a little bit of a different metric on what do we get in these. And I consider that 10,000 hydrocodone is 10,000 hydrocodone that my kids can't get access to. So we consider this project a success. With this project, we're going to do some targeted media and see how that impacts drug donations. We're going to go into some communities, some counties that don't have these yet, and see how we can impact what they're able to get donated from their residents. ETSU is visioning for its 125th birthday. We just started that process, I guess, in 2011, 2012. And in the same way, the Prescription Drug Abuse Working Group is visioning. And our vision is for this place to be a hub for prescription drug abuse research, outreach, education, training, and treatment. We want this place to be all-encompassing. It's a place that the Appalachian region can look to get help with prescription drug abuse in their communities. And so we're doing our best to get some evidence-based things going here to help you all. And we would encourage you to contact us if there's anything that we can do to help you. It's definitely something that there's a lot of people here, a lot of expertise, and we're very willing to help. The next thing we're going to do is look at potential demand. We haven't talked about that much today, but that's really looking at prevention. We're going to have a discussion later about supply, which we usually consider prescribing behavior, prescription drug monitoring programs, and then law enforcement. And then demand, which is the treatment. The potential demand is a concern. And that's where we're trying to get people to stop, to not even experiment, to not even go there. So if you consider this a triangle, you've got supply, demand, potential demand. We've established, or we just submitted Monday, a big grant to the CDC to establish an ETSU Prescription Drug Abuse Prevention Research Center. Whether they find it to their liking or not, I don't know, but what we're trying to do with this project is look at potential demand. We're trying to blanket the area, prescribers, dispensers, everybody that comes into a pharmacy or a prescribing office ought to leave, especially if they're being prescribed an opioid pain reliever, ought to leave with information that talks about how to dispose of it when you're done, how to monitor your kids, how to secure it in your home, what's even the abuse potential of this drug, and where do you get help if you need it. Couch that with a positive youth development piece, and that's where we're trying to go. And our hope is really that through decreasing the potential drug demand, that eventually, with your help and with everybody's help, taking these efforts in aggregate, that we reduce prescription drug abuse and misuse as a whole. I think we're on the right path to that. Like I said, I'm blessed to be a part of it, and doing good things here. Take advantage of us. Thank you very much.